Hello, everyone. Thank you for listening to this talk. My name is Julian Dassa, and I'm a surgery resident at the University of Toronto. I'll be presenting some of this work on behalf of my colleagues and mentors at McMaster University. For the next 8 minutes, I'll be speaking about learning curves in laparoscopic liver surgery. We know that there's a substantial amount of evidence from observational studies that laparoscopic liver resections lead to faster recovery, less blood loss, and lower complication rates. However, we now have evidence from 3 separate randomized clinical trials. And even though the results of all 3 studies are somewhat different, some showing benefits and others don't, the main takeaway point is that laparoscopic liver surgery is at least as safe, if not better, with respect to complications, blood loss, and hospital length of stay. A survey of Canadian HPV surgeons in 2017 explored surgeons' attitudes towards the uptake of laparoscopic liver surgery. Mind you, this survey was published when we didn't have as much randomized evidence as we do now. Nonetheless, most respondents wanted to incorporate MIS into their practice. However, perceived barriers that predominated were lack of exposure to MIS during training, uncertainty about the benefits, or time constraints in training of support staff. I'm going to focus on this issue of lack of exposure during training. What exactly does that mean, and how much exposure is enough? If we go back to the 3 randomized trials that I presented earlier, all were performed or supervised by 1 or 2 experienced surgeons. So how do these results translate to the HPV surgeon with no expertise in MIS liver surgery? And what about the HPV fellows who are in the midst of their training? There needs to be direction about the level of mentorship and direct observation that is required to safely gain competency in this new technique. As such, the aim of our project was to define and characterize the learning curve of laparoscopic liver resections. To do so, we retrospectively collected data from 5 surgeons on every laparoscopic case they had ever performed, including their very first case ever. This meant that we had to go back to 2005 when the first laparoscopic liver resection was done at our center. To give you some background about our center, we are a high-volume HPV center located in the province of Ontario, where the practice of HPV has been regionalized for many years. Our 11-year experience resulted in 324 resections, some of which were done completely laparoscopically and others using a hand port in the right upper quadrant. Unlike other learning curve series, we included all cases, both minor and major resections. We felt that it was important not to be selective about the etiology or the extent of the procedures. When studying the learning curve of a procedure, prior cases, big or small, help you become better for the next case, and so on. First, we divided cumulative cases performed by each surgeon into blocks of approximately 15 cases. We used the first 15 cases as the reference for our subsequent regression analysis. We used the combination of mixed effects, linear and logistic regression to model each of our outcomes, linear for continuous outcomes and logistic for binary outcomes. We used mixed effects models with a random intercept at the surgeon level to account for the correlated nature of our data. We estimated regression coefficients using a Monte Carlo Markov chain. Each model was adjusted for variables that we felt could impact the learning curve of each surgeon due to different selection practices. For instance, we anticipated that some surgeons would perform smaller cases early in the learning curve. Therefore, we adjusted for age, sex, comorbidities, cirrhosis, preoperative chemotherapy, diagnosis, and resection size. To characterize a learning curve, 2 separate measures of learning are needed: measures of technical proficiency and measures of patient outcomes. For technical proficiency, we focused on operative time and conversion to open, and for patient outcomes, we focused on morbidity, blood loss, and prolonged admission. We define morbidity as any complication using the Clavian-Dindo classification, as well as unplanned readmissions within 90 days. Prolonged admission was defined as a stay greater than 7 days, as this was based on the highest quartile of admission length in our study population. Here's a summary cohort of our population. The mean age was 62 years old. 43% of patients were female. The age-adjusted Charlson comorbidity index was 6. Most of our cases were for colorectal liver metastases, 12% were for HCC, and 26% were for other etiologies, including intrahepatic cholangiocarcinoma and benign conditions. As I mentioned, we included 342 consecutive liver resections, of which 40% were minor, meaning 2 segments or less, and 51% were major resections, meaning 3 segments or more. As I said before, we carefully inspected relevant patient characteristics, not just in the full cohort, but also in cumulative blocks performed by surgeons. What we wanted to explore were any large differences in patient selection throughout the learning curve. I'm going to focus here on major resections, for instance. As you can see, the first 15 cases had fewer major resections compared to the rest of the cumulative blocks. We can see that same data on this graph. We found that over time, the proportion of major resections compared to minor was higher. We can confidently say that our results are not merely due to selection of easier cases over time, because in fact, the opposite was true. Surgeons' confidence to take on larger cases grew over time. Now I'm going to present some of our results. The first is operative time. Mean operative time was 5 hours for the first 15 cases across all 5 surgeons. That is not shown in the graph. What we see here is the adjusted operative time for each cumulative block of cases thereafter. We see an obvious downward trend with experience, and by 50 cases or more, there's a significant reduction in operative time by 1.4 hours. We see similar patterns with respect to the adjusted odds of conversion and prolonged admission. For example, after surgeons had completed 50 cases, the odds of conversion were 55% lower, and the odds of a prolonged admission were 73% lower compared to the first 15 cases. We did not find a similar pattern with respect to blood loss or with respect to all-cause morbidity. From this, we conclude that it requires 50 cases before surgeons saw improvement in technical proficiency and patient outcomes. Importantly, patient morbidity was not compromised early in the experience. Whether or not this is due to patient selection changing over time remains unclear. However, we try to mitigate this using regression analysis by controlling for any potential selection factor that we could record. That is not to say that 50 cases equals mastery. It is very possible that over time, further improvements can be observed. It's possible that we have only identified the first inflection point in the learning curve, and we have not described the full learning curve with a plateau in the end. It is also important to keep in mind that these were average results for 5 surgeons, but every surgeon has his or her learning curve depending on personal characteristics, available mentorship, and MIS training. What we have yet to explore is how different factors such as simulation, proctoring, and training of support staff affect the learning curve. These are my references. Thank you for listening, and I'm happy to take any questions in the question period.